Hello, everyone. I am Rahul Gossain,
And I'm Rohit Gossain.
and we are Oncology Brothers. Today with us, we have Dr. Harold Burstein, a world-renowned medical oncologist from Dana-Farber Cancer Institute. We're hoping that Dr. Burstein will walk us through his approach in treating HER2-positive breast cancer using an algorithm. Al, thank you so much for joining us.
I'm glad to finally be with the brothers.
Well, that's very kind of you. Thanks so much for taking the time, Hal. So, diving into our early stage. Hal, here we often, especially when less than 2 centimeter or node negative, we proceed with surgery, followed by adjuvant TH, that is paclitaxel and trastuzumab for 12 weeks, followed by radiation and complete a course of trastuzumab for about a year time. How does your management truly differ if it is less than 1 centimeter or if the disease is between 1 to 2 centimeter?
Sure. So, as this audience knows, when trastuzumab was being developed, it was essentially piggybacked onto ACT-type chemotherapy regimens. So you got AC, and then you got paclitaxel with or without the addition of trastuzumab. And that was a tremendous advance, obviously, one of those handful in a career kind of drugs that you see come forward and became the standard of care. Patients who had smaller stage 1 cancers were not eligible for most of the pivotal trials of adjuvant trastuzumab, and it was not known if all of that treatment would be necessary for them. So our group, a trial led by Sarah Tallaney, and our group provide a lot of leadership on this, did the experiment of essentially just lopping off the AC phase of treatment. We prospectively treated around 400 patients who had stage 1 HER2 positive breast cancers. And the goal was to show that if you gave paclitaxel trastuzumab or TH, that there would be a very low risk of cancer recurrence. And what we showed in the original publication and has been documented in longer follow-up is great results for that group of patients with systemic recurrence risks of less than 4 to 5%, a couple of extra percentage points of local recurrence, but a very favorable overall long-term prognosis. So that really has become our go-to regimen for tumors that are 2 centimeters or less. An interesting question is where you draw the lower limit of treatment. And there's no actual rules or guidance on that because no one's done a study of, what's the best treatment for 3 to 4 millimeter HER2 positive cancers. As part of our St. Gallen consensus panel activities, this is a group that meets every 2 years and issues guidance for treatment of early stage breast cancer. We have surveyed the panelists and asked them what size threshold tumor would make you recommend adjuvant treatment for a HER2 positive cancer. And what's interesting is the break point is right around 3 to 4 millimeters, which seems kind of like a crazy amount of cancer to be treating. But right there is where most oncologists surveyed would begin to recommend adjuvant TH therapy.
Thanks for going on with that. And I know that, as you mentioned, the importance of adjuvant treatment here. Now, is there any role for neoadjuvant treatment here in less than 2 centimeter and node negative, especially when we rely on pathological response being a prognostic marker here?
Yeah. So you make a great point, which is in higher stage HER2 positive cancers, neoadjuvant is the preferred approach, and I'm sure we'll be talking about that momentarily. For stage 1 cancers, when the axilla is clinically node negative, I think it's really hard to see that you need to offer neoadjuvant treatment for a couple of reasons. One is almost by definition, they are operable at that point. They can have breast conserving surgery. So none of the surgical benefits of downstaging the tumor really come into play, except in really unusual circumstances, you might imagine. The second is that, if unfortunately you undergo surgery and the patient is found to have more extensive disease, we still have excellent therapies for that in the way of regimens that we'll talk about, built around trastuzumab and pertuzumab and chemotherapy. So it's not like you forfeit a major opportunity to do that. So in our practice, stage 1, tumors right around 2 centimeters or smaller, we're usually using just surgery first. If it's 2 centimeters or bigger, or if there's nodal involvement, I think neoadjuvant is the preferred approach.
Al, thank you for going over that. And you've mentioned post-surgery, if the patient is upstaged with their disease. Now, let's say you have node positive disease, then adding pertuzumab is a fair option, and that's based off affinity trial. talking about upstage, this is a good segue to locally advanced, where dual anti-HER2 can potentially play a bigger role. How your treatment approach for a larger tumor or node-positive disease?
So exactly as you just said, we know that adding another anti-HER2 targeted drug here, pertuzumab, does a couple things. So one is in the AFFINITY trial, it improved the rate of longer-term tumor control, and in several preoperative studies, it was shown that it improved the rate of complete pathologic response. So based on that, our preferred approach for tumors that are 2 centimeters or bigger or thereabouts, or that affect regional lymph nodes, would be a preoperative treatment plan. We usually use TCHP. There's controversy over whether some patients should still get anthracyclines or not, but we usually use TCHP, 6 cycles of that, and then they would proceed to surgery. And here's an opportunity, and your algorithm captures this, which is to tailor the adjuvant phase of treatment based on the extent of response to the TCHP. So approximately 60 or 65% of the patients will have a complete pathologic response with TCHP. About a third, 30 to 40%, will have residual tumor. For those with residual tumor, we know that switching them from an HP-based maintenance regimen over to TDM1 or trastuzumab emtansine can further reduce the risk of recurrence. And at the San Antonio meeting just this past December, there was long-term follow-up from the Catherine trial, which very nicely showed that, as had been earlier reported, it reduces the risk of recurrence. Now, with longer follow-up, a clear survival benefit and a meaningful improvement in disease-free survival as well. So this is a nice example where the preoperative model is clearly preferred. It achieves surgical downstaging for the breast and the axilla. It provides highly effective adjuvant treatment, and it allows us to tailor or individualize the treatment on the backside based on the extent of response.
Right, just to reiterate that, that was magnificent results that we saw, about 8-year follow-up with IDFS and overall survival benefit from Catherine trial utilizing TDM1 and residual disease. Now, talking about the adjuvant setting, how much truly is pertuzumab adding here if one was to undergo surgery?
It's a great question. And, in the AFFINITY trial, there was modest benefit in terms of overall survival, particularly in the node positive group. We tend to recommend pertuzumab only in the setting of node positive disease or in the preoperative setting. In the preoperative setting, we really use it because it's more likely to achieve a pathologic complete response and therefore spare someone perhaps the need for the TDM1 on the backside. So it's ended up, being an important part of the regimen, though, I think in smaller tumors and in the maintenance phase, one could ask whether it's proven to be essential. I'm not sure that it's truly proven to be essential in those contexts, but we still use it.
How you mentioned controversy around anthracyclines. At SABCS 2023, you presented a discussion around that. In your clinic, is there any patient that perhaps would get anthracycline in HER2 positive disease? And then talking about controversy, I would also like to know who is getting neratinib.
Sure. So at San Antonio, I had the pleasure of being the moderator for a great debate between Martine Picard and Ginger Borges on the role of anthracyclines. And as we said a moment ago, anthracyclines followed by taxanes were sort of the core regimen prior to the development of trastuzumab. And actually, in some beautiful retrospective work from Dan Hayes and others, the group of tumors that most benefited from anthracycline-based chemotherapy were, in fact, HER2 positive breast cancers. So there was a clear biomarker rationale for continuing anthracyclines. Having said that, if you look at trials like the BCIRG trial and several of the other studies that have come forward since then, it's hard to see that anthracyclines still have a major role, particularly when you're giving dual anti-HER2 therapy. So if you look at a neoadjuvant study like the TRIFIENA study, when you gave TCHP, you saw path CR rates that were exactly the same as anthracycline-based regimen with trastuzumab and pertuzumab. So given that, and given the side effects of the anthracyclines, I think most Americans have actually moved away from anthracycline-based chemotherapy. Though what was interesting at our debate is that around the world, anthracyclines remain widely available, widely used, and are still a major component. I would say that TCHP is our standard go-to for these stage 2 and 3 HER2 positive cancers.
Absolutely. And you and Roy touched base on residual disease with the Catherine trial. Coming back to neratinib, who is getting
Oh, yeah. So
neratinib in your
neratinib.
clinic?
Sure. So neratinib was studied in the adjuvant setting in the ExteNet trial. So as the audience knows, neratinib is a small molecule tyrosine kinase inhibitor, which is orally available. So neratinib was studied in the ExteNet study for patients who'd had 1 year of trastuzumab and then were randomized to ongoing therapy with neratinib or no further treatment. The study was done at a time before the availability of pertuzumab and before the availability of TDM1 in the refractory neoadjuvant setting. And in that study, there was a benefit for continuing therapy with neratinib, particularly in women who had ER positive, HER2 positive cancers. So that is an option. Having said that, we don't actually use all that much of it for a couple reasons. One is that nowadays with the use of both trastuzumab and pertuzumab, it's unclear that there would be a further role for ongoing extra year of neratinib-based therapy. Secondly, as we've just been discussing, the Catherine data give us a salvage opportunity, if you will, in the residual disease setting. Third is the drug had, fairly substantial side effects, particularly diarrhea and lower GI toxicity, which made it hard to complete the course of treatment. So it is an option for very high risk tumors that are ER positive and HER2 positive, but I would not say it's a standard component for the vast majority of women with HER2 positive breast cancer.
Thank you for covering that. And again, in my practice, same thing. I've rarely used neratinib.
Yeah.
Now let's dive into metastatic disease. Hal, your take here. There's a lot happening.
So current practice, our algorithm would be THP, and then sort of as you've indicated, shifting to the maintenance phase of HP. If the tumor is also ER positive, I often introduce endocrine therapy at that point as well. And then they're followed. If they should progress in the future, then they have options of reintroducing the taxane or switching to TDXD or switching to TDM1, which is a little bit less toxic, or using the tucatinib-based regimens of trastuzumab, capecitabine, and tucatinib. We don't exactly know which of those is the best for long-term results because most patients are going to get most of these regimens. And so it's not a question of now or never. It's just a question of what regimen do you pick next. So once you get beyond those 4 regimens, then there's a whole raft of other choices that you might choose, such as chemotherapy with trastuzumab. And here we use a lot of eribulin or platinating chemotherapy or vinorelbine-based chemotherapy. There are small molecule tyrosine kinase inhibitors, though we don't actually know a lot about the value of those drugs like neratinib or lapatinib after tucatinib-based regimens. You've listed here margetuximab, which is another alternative to ongoing trastuzumab-based therapy. And we know that most patients will get somewhere between 8 and 10 lines of treatment for HER2 positive metastatic disease. So I think it's hard to be too dogmatic here, but that's kind of our algorithm and how we think about it.
Thanks so much, Hal. And these are just certainly very exciting times. When did we ever think about in advanced disease we'll be having maintenance talk for years and years time, and then you're talking about even second and third line and 8 to 10 lines rather. Now, we know that we have well-established first-line regimen, THP followed by HP. In second line, we have very promising data from HER2 Climb with the triplet regimen, and San Antonio Breast Cancer Symposium, we saw TDM1 combined with tucatinib and HER2 Climb 02 regimen with CNS metastatic disease too. And TDXD also has CNS activity. When a patient with CNS Mets does come to your office, how do you maneuver through this treatment algorithm?
I call the Lynn rule after Nancy Lynn, my colleague here at Dana-Farber, which is that the best drugs for the CNS are found by finding the best drugs that work outside the CNS. There's no magical drug that works like in the brain that doesn't work everywhere else in the body. So the way to screen for drugs that are active in the CNS is to screen for drugs that work really well outside the CNS, and that's how tucatinib, TDM1, TDXD have all been developed. I think most of this is driven by, what you think of as your best agent. So in patients who have not had TDXD, I think many of us would reach for that as the first choice. Tucatinib, trastuzumab, capecitabine clearly has activity there as well. And as you mentioned, there was a cohort of patients in those trials who had prior CNS disease and were included in the study and clearly benefited as well. So the biggest issue there has been that it's changed the way we think about managing CNS mets. So in a patient who has minimal disease in the CNS, but multiple lesions, we might actually try a drug-based regimen first instead of doing whole brain irradiation. For isolated lesions, we still think a lot about surgery, or more commonly stereotactic radiosurgery, and then coming in with some of these drugs that are known to have CNS activity. But that's been a real transformation as well, given the potency of these drugs in the CNS. And it's a similar story to when you start talking about, your ALK-associated lung cancers and alectinib and other situations where you have highly potent drugs that work within the CNS.
Absolutely, exactly. We've seen a lot of this, especially in lung cancer, where we're relying on oral actionable mutations that you can target, and you have phenomenal responses,
Yeah.
even with CNS disease. How, so in this situation, once the disease has progressed, second line, you've mentioned margetuximab, we have it up here. SOPHIA trial was the one. In the final update, it did not show overall survival benefit. Also, TDM1, we don't have much data on how to use another ADC once you've used TDXD. How do you go about in third or fourth line settings?
Yeah. So, I think the first thing to emphasize is that, again, there are major marketing issues here, and it does obviously affect the duration of the course of therapy. But what we don't know is there really a clinically and biologically definable strategy that's best? So, I think this is why here in the setting of metastatic disease, where we historically have not focused on longer-term overall survival, the fact that drugs like TDXD and combinations like tucatinib with trastuzumab capecitabine are showing overall survival benefit is really important. But now that they're in the market, what you want to say is, are they showing survival benefit because you use them in second versus third line or first versus second line? Because unless you plan crossover, all you're doing is just saying, well, the drug is still active. And I'd like to see more trials where there was planned crossover with some of these more potent regimens. Having said that, I think for most of us, if the patient's tumor is resistant to a THP type regimen right now, then TDXD, which outperformed TDM1 quite readily, would be the next choice. Beyond that, I think it's a dealer's choice of the tucatinib trastuzumab capecitabine versus the TDM1 based regimen. We don't really have much data for either of those after TDXD. Fourth line is whatever you didn't use in the third line at that point. And then once you get to fifth line and beyond, you have the choices that you've listed here, and we all use these kinds of regimens, but there really are no data whatsoever on how these stack up against either these contemporary ADC-based programs, pertuzumab-based programs, or after a prior TKI-based therapy. So we use all these things, but there really isn't a lot of data to say which is the preferred one and which way to go.
Thanks for covering that, Hal. Before we close, just a quick thing on side effects, as it matters from quality of life standpoint for these patients. I know that with TDXD, the common ones that we see are fatigue and nausea, which in community we are very well able to manage that. But the dire complication is pneumonitis, which is associated with mortality here. Hal, what is your clinical practice here and some of the important clinical pearls that you'd want us to learn from that?
Sure, it's a really important point. We're seeing a lot of pneumonitis as a side effect of our breast cancer drugs. It's a black box warning for the CDK4/6 inhibitors, and obviously part of the TDXD label as well. So the first thing to say is it's important to alert your clinical team, your nursing staff, and your patients that this is a potential side effect. So if they have shortness of breath, dyspnea, you want to hear about it sooner rather than later. It's almost always treatable with early intervention, high-dose steroids, and other supportive care, but it's important to have a low threshold to evaluate patients for this. Now, having said that, our radiologists are very aware of this also. And so all the time when patients are on these drugs, they're saying, well, maybe there's a little tiny bit of ground glass opacity or something like that. And, there are elaborate algorithms that have been published that you can read to sort of gauge whether or not to, halt treatment or see if things get better. Of course, there's tons of flu and COVID around now as well. So a lot of patients are getting upper respiratory infections with ground glass opacities, and that can confuse things as well. So, you have to use your clinical judgment here to sort all this through in a constructive way. I do think it's something you have to pay attention to, though. So we tend to get staging scans every 12 weeks or thereabouts, and that's usually when we look for ground glass changes or other evidence for pneumonitis. Again, the warning labels might say perhaps more frequent CT imaging. When I talk to clinicians around the country, that is probably perhaps a good idea, but not always done so every 6 weeks or things like that because of the realities of care. But it's just something that I think people need to be very alert to. And again, educating the patients is probably every bit as important as educating the clinical team.
Thanks so much, Hal. Well, we've covered a lot in the past few minutes here. Hal, thank you so much for joining us and going over the current standard of care for HER2 positive breast cancer. For our listeners, let us go over a quick recap. With Dr. Harold Burstein from Dana-Farber, we have covered the current standard of care treatment options for HER2 positive breast cancer. In early phase, adjuvant trastuzumab and paclitaxel based off of APT trial remains a good option. In a large tumor and or node positive disease, specifically more than 2 centimeter, neoadjuvant chemotherapy and anti-HER2 therapy play an important role.
And then in metastatic disease, starting off with dual anti-HER2 therapy along with docetaxel at this time remains the mainstay. Then TDXD or tucatinib-based regimens are feasible treatment options.
We will eagerly await on full data for tucatinib and TDM1 combination from HER2 CLIMB-02 trial, especially with intracranial disease. With more and more use of TDXD in our clinic, we also have to appreciate how to manage some of these important side effects from all these particular agents. Thank you for joining us today. Also, check out our triple negative and hormone receptor positive breast cancer discussions. We are the Oncology Brothers.